Hello everyone, this is PESCI Girl talking. We are back with clinical cases. This is the first case, red rash on the buttock. We are going to describe the lesion, talk about differential diagnosis and how to differentiate them, and the management. Tom is a 42-year-old male with a rash on the buttock from 1 week ago. In past medical history, Tom has diabetes mellitus type 2, no allergy to any medication, and he has been on metformin 500 mg twice a day, and he's been trying hydrocortisone 1% cream for 1 week, but there has been no resolution. So first, if you want to start with description of the lesion, we can see an annular erythematous patch that is poorly demarcated from the normal skin. There is no scaling, no pustule, no vesicle, and no bullous lesions. The first diagnosis here is tinea. Now in classic tinea, we expect to have an active margin, a well-demarcated lesion with central clearing and scaling around. Now remember, this patient has been on corticosteroid for 1 week, so we don't expect to see the classical symptom of tinea that we do. The other one is psoriasis, but flexural psoriasis or inverse psoriasis that usually happens in skin folds such as axilla or genital area or in buttocks. Now remember, in this kind of psoriasis, we don't expect to see the thick scales that we usually see in psoriasis. The other differential diagnosis would be contact dermatitis. So we can ask the patient if he has been using a kind of shampoo or a cleaner or a new material shorts or pants. Another differential diagnosis is candida. Candida is especially important in this patient because that he has diabetes and he is also obese. Swab and skin scrapes for bacterial and fungal microscopy and culture help to differentiate the causes of this lesion. Tinea and Candida intertrigo are readily diagnosed on microscopy and fungal cultures. We can do skin scraping on the leading edge of the lesion with blunt side of the blade number 15 usually. So an important point in this case is this patient has been on corticosteroid treatment that causes less scrapes. So we want to stop treatment for several days, and then when the scrapes is back, we can ask the patient to come back for scraping for microscopy and culture. Another invasive method is skin biopsy and histology. Skin scraping with potassium hydroxide shows segmented hyphae, which is diagnostic of the tinea infection. So, as the first line, we use topical terbinafine twice daily for 2 weeks, and we check the patient to see if the lesion is getting better or not. Meanwhile, we ask the patient to regularly wash underpants or other piece of clothing which is in contact with the rash. We ask the patient not to touch the area, and if the area is touched, to wash it carefully. And we check the patient after 2 weeks to see if it is resolved or not. Tom's rash gets resolved by 2 weeks. However, he comes back after a month with a similar rash in groin area. In case of recurrence, we're thinking about a primary site that acts as a reservoir for infection. Usually, this site is the feet and the toenail. So in this case, we examine feet and toenail and find that the Tom has onychomycosis. Treatment for this is terbinafine oral and usually requires a long time treatment.